So let's really try to relax. The talk is designed for hopefully you not needing to take a lot of notes. If you want to relax and just really have a smooth ride the rest of the afternoon, hopefully you can do that. No conflicts of interest to disclose. Over the next few minutes, we're going to review some important physiology aspects of the mechanical breath, specifically the pressure profile that is very important to the overview of pulmonary mechanics and patient ventilator desynchrony, and discuss the differences between passive ventilation and supportive ventilation in the setting of active respiratory efforts, which is also very important. And we'll describe different hemodynamic effects that may occur under different modes and some other key ventilatory concepts that will be for your review towards the end of the talk that hopefully we will have enough time to cover those. So the first part of the talk has to do with the pressure profile of the mechanical breath. And I want to direct your attention to the first, I think the mouse is not helping. Oh, here. To the first portion of this waveform, so the flow phase. And it ends at the peak inspiratory pressure. And the important aspect to remember here is that this flow phase will represent everything that tidal volume that we are delivering to the lungs have to overcome, including the airway resistance, any type of mucus, the weight of the chest wall, etc., in order to deliver that tidal volume. Then, in the second phase, the pause phase, this is generated at zero flow. This represents the alveolar pressure in the setting of equilibrium. So if we really want to know what pressure is the alveolus sensing, that will be your plateau pressure. And we're going to discuss important aspects of the difference between the peak and the plateau pressure in the clinical setting. And the third phase is the end-expiratory phase. So normally we think of FRC in patients that are spontaneously breathing. But in mechanically ventilated patients, FRC is represented by the end-expiratory lung volume. And in the perfect scenario, without any kind of air trapping or auto PEEP, that is determined by the PEEP level that we set on the ventilator. So let's try to keep those aspects in mind as we move forward to the presentation. The second important portion of the physiology behind mechanical ventilation is trying to, at the bedside, identify which portion of that respiratory system compliance equation is actually responsible for the low compliance status of the patient. So is the respiratory system compliance low or high because the lung compliance or the chest wall compliance contribution? And as we dive more into these equations that perhaps are important to not memorize but understand, when we talk about compliance, we talk about a static component, meaning we talk about the differences in volume over differences in pressure at the extremes of the tidal cycle, meaning the volume difference between expiration at rest and the volume difference between inspiration at rest. So the change in volume in the static compliance calculations is going to always be represented by the tidal volume. And then we have different components for the pressure differences at the end of the cycle, at the end and beginning of the cycle, depending on what compliance are you referring to. So normally we talk about respiratory system compliance, and these are, this is the variable that we can measure and calculate with the pressure values that we obtain from the ventilator. So these pressures are measured outside the patient. If we want to know and estimate the lung compliance and the chest wall compliance, we need another instrument. And that instrument is going to be the esophageal pressure. We use the esophageal pressure because it is a surrogate for your pleural pressure. And at that time, then the differences in pressure between the extremes of the tidal cycle is going to be your esophageal pressure at the end of inspiration and at the end of expiration. When we're talking about lung compliance, however, we talk about a very specific pressure that is responsible for the inflation or deflation of the alveolus, and that is the transpulmonary pressure. The transpulmonary pressure is nothing more than the difference between your alveolar pressure. In this case, at the end of inspiration, your alveolar pressure is going to be your plateau pressure, and the pressure in the pleura at the end of inspiration, represented here by your inspiratory pressure. So plateau minus esophageal pressure at the end of inspiration is going to be your transpulmonary pressure at the end of inspiration. And your PEEP minus your esophageal pressure at the end of expiration is going to give you the value for the transpulmonary pressure at the end of expiration. So important to remember the differences of this, because all of these are interplaying when we are ventilating patients at the bedside. And the next important aspect of the mechanical ventilation is discussing the equation of motion. And perhaps social media has made this a little bit too complicated, and it's really not that difficult at all. The equation of motion dictates how the patient and the patient efforts interact with the ventilator that is trying to insufflate the lung of the patient. There are different permutations of that equation, but we're going to concentrate on the last one. And we're going to do this very clinically. So I want you to go back to that memory of ventilating a patient that had a very fibrotic lung, or along with a lot of consolidations, or an advanced ARDS patient. So that patient is going to have a very low lung compliance. So if you have a low lung compliance, this is a denominator in this equation, then delivering any type of tidal volume, let's say 400, is going to result in an increase in the total airway pressure, right? The same would happen if you try to deliver the 400 tidal volume to a patient with an increased airway resistance. So the total pressure is going to be directly proportional to the airway resistance of the patient. And the same would happen with the flow. If you have a peak flow of, let's say, 50 liters per minute, and you're delivering 400 of tidal volume, if you increase it to 70 or 65, you're going to have resulting higher airway pressures. So that is the relationship between lung compliance, airway resistance, and flow to the total pressure. But the total pressure is also the relationship of the pressure that the ventilator used to deliver that tidal volume, and also the pressure that the patient is generating in every effort. So that is called PMAS. So if the patient is making active inspiratory efforts, the patient is generating a negative pressure. So a positive pressure from the ventilator minus a negative pressure is going to result in a reduction of that total pressure at the end of the inspiration. And the same happens if the patient is trying to fight the ventilator or is exhaling as the tidal volume is being delivered to the lungs. So we're going to look more of these interactions, and we're going to see how this actually plays a role in waveform analysis. So here you have the example again. On the left, we see an active effort, a patient that is having active inspiratory efforts. And on the top, you see the flow over time waveform. In the bottom, you see the effect of that effort on the pressure over time. And suddenly, we either deplacidate the patient or we paralyze the patient, and we see that we remove that PMAS contribution of negative pressure. So the only pressure that is acting on that total pressure is the ventilator pressure, which is a positive pressure, and the total pressure is going to be higher, all right? So we have another representation here, and this is the principle for any type of patient ventilator desynchrony and evaluating the comfort of the patient. So we have here 3 examples of different modes of ventilation. We have control mandatory ventilation, we have spontaneous ventilation, and we have partial assist ventilation. I want you to initially drive your attention to the esophageal pressure that in this case is giving you an idea of the effort of the patient. So as you can see, the deflection or the deflection of the esophageal pressure is actually positive, because any change in the pleural pressure is going to be secondary to the pressure that the ventilator is doing, which is a positive pressure. As the patient starts to either have full respiratory efforts, the esophageal pressure becomes negative, and you can see the effect on the alveolar pressure here, which is a reduction in that total alveolar pressure that you will see on the ventilator. And of course, if you have not as a robust effort, but just a partial assist by the ventilator, then you will see a reduction in that total pressure, but not too much of that kind of flow starvation that we're going to discuss later on. And this is what we are seeing here when the patient is active and the different changes in the pleural pressure. So with those concepts in mind, and I'm sorry that is kind of a heavy portion of the talk at the beginning, but it's really important to discuss those topics to actually move forward with what we call the trilogy of the mechanical breath in patients that are mechanically ventilated. And that is the trigger, the target, and the cycle. And we probably have heard this a lot of times, and we try to describe the modes in using this three item nomenclature. But it's actually, again, very simple. So the trigger is that variable that the patient is going to overcome in order to trigger the ventilator to deliver a mechanical breath. And that can be either pressure or flow if the patient is generating some spontaneous effort that can generate that pressure and flow differential. Or it can be simply time, right, if the patient is completely passive. So the breath is going to be delivered based on the set respiratory rate. The second item is the target of the mechanical breath. And this used to be called the limit of the mechanical breath. And it's basically that variable that is maintained and not exceeded during the inspiratory phase of the mechanical breath. That can be pressure, flow, or volume, as we're going to see shortly. But it doesn't necessarily finishes the breath or dictates when the patient is going to move from inspiration to expiration. That is dictated by the cycle variable. So the cycle is the variable that uses that the ventilator uses to actually transition the breath from inspiration to expiration. That can be either after delivering a certain amount of tidal volume, or using a certain amount of time in inspiration, or after sustaining a certain amount of pressure for a certain amount of time. So all of that is basically put together in the basic nomenclature of ventilator modes. So let's discuss very briefly volume control and volume assist ventilation. So volume control, meaning the patient is completely passive, the trigger is going to be dictated by your respiratory rate. So after a specific amount of time, a mechanical breath is going to be delivered. Normally, when you set volume control ventilation, the peak flow rate is going to be fixed and constant. So that variable is going to be not exceeded during the inspiratory phase of the mechanical breath. But the breath finishes, or the transition from inspiration to expiration occurs after the amount of tidal volume you have set is being delivered during that inspiratory phase. So if you think about it, the inspiratory time in volume control is basically dictated by the size of the tidal volume and the peak flow that we set on the ventilator. So a larger tidal volume and a slower peak flow is going to result in a prolonged inspiratory time. If I have smaller tidal volumes and very fast peak flows, the time of the inspiration is going to be shorter, all right? If the patient is having some respiratory efforts and is able to trigger the ventilator, that will be volume assist. The only difference now is that the trigger is not necessarily time. The patient can breathe over the set respiratory rate that we have on the ventilator. But now you can use either peak or a pressure or flow as a variable to trigger the mechanical breath. Now let's take a look at the pressure control mode. Again, very simple. If a patient is completely passive, it's going to be the respiratory rate that is going to dictate the trigger of that mechanical breath. The variable that is not going to be exceeded during the inspiration is going to be your inspiratory pressure. And the timing that the variable that is used to transition from inspiration to expiration is going to be time. So we set the inspiratory time in pressure control. The volume now is resulting from either the patient effort or the mechanics of the lung and the chest wall. In pressure assist, we can also trigger based on effort using either pressure or flow parameters. And if the patient is breathing below a certain amount of respiratory rate and the backup rate is triggered, then the cycle is going to be determined by time. But pressure support ventilation has the peculiarity of using a very special criteria to transition between inspiration and expiration. That is called the flow decay that we're going to review here shortly. The rest of the permutations, as you can see below, including synchronized intermittent mandatory ventilation, can be those mandatory breaths or controlled breaths can be delivered either on volume control or pressure control. And of course, they allow also pressure support ventilation and spontaneous breaths in between. So we're going to use this criteria and nomenclature in the next a few slides. And really the goal here is to get you very familiar with pattern recognition and understanding how to recognize these different modes, because that seems to be a very frequent way to test this on boards. So the first question is, which ventilated mode is shown here? A, pressure control mandatory ventilation. B, synchronized intermittent mandatory ventilation. C, volume assist control ventilation. And D, proportional assist ventilation. I want you to pay attention to, again, what variable is not exceeded during inspiration, and to pay attention to which variable is actually showing changes. All right, so I think I have to scroll down just to show you the answer here. So great, again, I probably have to make these questions a little bit harder next time. The right answer is volume assist control ventilation. Excellent. So why is it not pressure control ventilation? So I want to just drive your attention to the red arrows. And as you can see, there is significant variation of pressure in that pressure over time waveform. However, you know, the tidal volume is pretty constant across all those breaths, including those that are initiated by the patient, here demonstrated by that little arrow, and also by the small deflection here at the beginning of the inspiration. And also we have a pretty constant flow pattern and a constant peak flow as we have set it on the ventilator. If we had pressure control mandatory ventilation, we will see no significant pressure variations across the different mechanical breaths. And we are not able to identify, as we're going to see here shortly, that intermittent pattern of spontaneous breaths and mandatory breaths as we see on SIMB. And when you see it, you will recognize it. Don't worry about it. Why is it not proportional assist ventilation? Well, proportional assist ventilation, to be fair, it will have to show you some idea of diaphragmatic activity. So PAV will use some degree of diaphragmatic activity and effort analysis in order to proportionally provide that support to deliver a specific amount of minute ventilation over time. So in this case, PAV is not the right answer. So again, the things that we set on volume control is going to be the tidal volume, your respiratory rate, and your peak flow. We're going to cycle off towards expiration when we finish delivering the tidal volume that we have set. The difference with pressure control relies on the fact that, as you can see here, there is some degree of desynchrony towards the end of the breath in this breath that is initiated by the patient. But you can see significant changes due to that effort on the amount of volume that this mechanical breath resulted in. And I just want to drive your attention to the very specific and constant inspiratory time that you will see regardless of patient effort with every mechanical breath. So an easy way to identify pressure control ventilation is going to be paying attention to your inspiratory time. APRV. So hopefully some APRV enthusiasts in the room. And an easy way to identify this mode is because it kind of is very similar to a pressure control mode with inverse ratio ventilation. So in APRV, we set basically two levels of pressure, a pressure high and a pressure low. The pressure high has a very specific amount of time that we also set on APRV, and that will be kind of a prolonged inspiratory phase almost that allows for also spontaneous breaths, as you can see here, during that high pressure time with a quick release time and a low pressure. So it resembles inverse ratio ventilation. The issue here is that it allows for a spontaneous effort, so we lose control of the tidal volume. And really, evidence-based doesn't support any specific mortality or outcome benefit over any other mode of ventilation. So any potential benefit at this time is speculative. There are other modes that provide a dual control. So we have talked so far about modes that use either volume or pressure, and we're looking at an output that is going to be either pressure or volume. But other modes manipulate both during inspiration, either following a specific volume target and proportionally changing the pressure, or using an analysis of previous breaths and trying to determine what is the effort of the patient. If I need more, I increase the pressure, or if I need less, I will reduce the pressure, keeping in mind the tidal volume target. So the first one that we will see often and that could potentially be tested on boards will be the pressure-regulated volume control, or PRVC. And basically, it starts as you set a desired tidal volume, and you set a specific maximum amount of pressure support that you're going to use, and you are also able to set an inspiratory time depending on whether the patient is deeply sedated or not. And what the ventilator does is basically analyzing the previous breath based on the efforts of the patient, and the pressure is adjusted. So meaning the goal of the ventilator is to reach a specific preset amount of tidal volume using the lowest amount of pressure possible. So if your patient is having substantial respiratory efforts, the pressure support level is going to be less. If the effort of the patient reduces because they go back to sleep or they become more encephalopathic, the pressure augmentation based on that effort analysis is going to be used. The problem here is that if you have a patient with a very erratic respiratory drive, then the ventilator is going to be playing catch-up all the time. So this is not the mode that is possible to be used with patients who have very high respiratory drive and erratic breathing. It could be a good mode to train the muscles and for extubating patients, but again, there's no scientific studies proving a benefit over simple pressure support trials. The second one that is a dual mode control that is possible to be tested is volume assured pressure support. And different to the previous one that we just saw, the augmentation of pressure actually happens immediately during the breath. So having a specific tidal volume in mind, we start with as pressure support ventilation, but if the ventilator senses that based on the previous inspiratory time of the patient, that tidal volume is not going to be reached, then it switches to an AC mode or assist control in order to augment the pressure and reach that specific tidal volume. And when we talk about modes and what evidence-based medicine says about superiority of a mode, well, the answer is there's no superior mode. The type of mode that could be determined to be best for patients depends on the culture and critical care team familiarity with the mode. There are some advantages. For example, volume control will assure a specific minute ventilation and a tidal volume over time. It doesn't control the pressure. Having a volume control setting may actually prompt the patient perhaps to, if inappropriately adjusted, trigger patient ventilator desynchronies, but perhaps have an advantage over following pulmonary mechanics, as we're going to see here shortly. I want to analyze this with you here. So we have basically three waveforms. We have the tidal volume waveform here. We have the pressure over time waveform here as well, and the esophageal pressure, giving you an idea of the patient effort. So here, under volume assist control ventilation, this is a passive mechanical breath. But here the patient actually makes an inspiratory effort. As you can see, there is a deflection on the pressure over time waveform and a negative deflection in the esophageal pressure. And you can see that distortion, again, the equation of motion reducing the pressure due to the P mass of the patient. But the transpulmonary pressure, meaning the difference between the airway in the esophageal pressure is going to be maintained. And the reason of this is we are controlling the volume of this patient. So any kind of transpulmonary pressure-mediated injury is going to be controlled or mitigated in volume control. But in pressure control, when we have a passive breath that transitions to a significant patient effort, you see a significant change in tidal volume. And as you can see, because of the negative deflection of that esophageal pressure and the persistent and constant inspiratory pressure that characterize pressure support, the transpulmonary pressure is quite significantly larger. And this could be injurious or not, depending on the amount of volume we have. So I feel that volume and pressure control, and this is what this evidence-based piece points towards, the pulmonary mechanic tracking can be actually better exerted in the critical care teams under volume control versus pressure control. But really benefit in outcomes is really difficult to follow. All right, question number 2. Which ventilated mode is shown here? SIMV, or synchronized intermittent mandatory ventilation, where the mandatory breaths are under volume control, or BC, pure pressure support ventilation, or SIMV, where the mandatory breaths are under pressure control, or an APRB mode, option D. Very good. Excellent. So let's scroll down here and see. All right, well, I'm not winning today. This is great. You are all winning. That's phenomenal. So this is an example of pure pressure support ventilation. So let's review why. So why is it not SIMV? Again, we're going to, when you see it, you're going to very easily identify this in the future. We are not able to identify those intermittent pressure mandated pressure control breaths that are basically in between these spontaneous breaths. So options A and C are not right. And again, we just discussed APRB, the components of a high pressure, low pressure, favoring a longer time of the inspiratory cycle in that high pressure level is also not seen in this particular example. The pressure support ventilation, we set the PEEP of the patient, we set the pressure support that we want to allocate for this particular patient depending on their effort and the weight of the patient, the position of the patient, etc., to maintain a decent amount of minute ventilation. What is particular about this mode, as we discussed earlier, is the cycling mechanism. So what determines a patient to go from inspiration to expiration in pressure support? And there is the percentage of flow decay. So this is basically the peak flow that the patient achieves at the end of inspiration will depend not only on the pressure support that we set on the ventilator, but also on the patient effort. That will be the 100% of the peak flow that we achieve with those settings. Now, the breath is going to transition from inspiration to expiration depending on the percentage of that peak flow that we set on the ventilator. So this is called expiratory trigger sensitivity. So if we finish the breath after 75% of that peak flow, the inspiratory time, or 50%, the inspiratory time is going to be very short. If we reduce the expiratory trigger sensitivity to, let's say, 25%, we're going to increase the inspiratory time and so on. So we use that parameter whenever we see dysynchronies at the end of the inspiratory phase in pressure support to adjust the inspiratory time of the patient, as we are going to see here. All right, question number 3. Which ventilator mode is shown? A, pressure assist ventilation. B, pressure support. C, SIMV, or synchronized intermittent mandatory ventilation, where the mandatory breaths are under pressure control, or APRB. Excellent. So let's see the results. Excellent. There's a little bit of a spread, but the right answer is SIMV, and those mandatory breaths were delivered using a pressure control mode. So very easy to, from the get-go, when we look at these images, this is what I wanted to show you, is that intermittent synchronized mandatory ventilation where we see very controlled mandatory breaths with associated in between spontaneous breath. So that's what you want to see in a test if we're going to be asked about SIMB. Why do we say those mandatory breaths are delivered using pressure control ventilation? Well, the reason is, if we pay attention, the inspiratory time of those breaths are exactly the same. We see a slight variation, perhaps difficult to detect with your eye right now, on the tidal volume, but the SIMB BC option is not in the answer. It's not a pressure assist control ventilation because we see different inspiratory times. If this was a pure pressure control assist ventilation, this and this will have also the same inspiratory time, and that is not the case. And again, it's not APRB. It's not that mode that favors a prolonged time on a high pressure resembling pressure control of inverse ratio ventilation. Excellent. So we're going to move to a lung protective mechanical ventilation strategies. And really, from the evidence-based perspective, there's just 4 pillars that could be potentially testable on exams. And that includes the lower tidal volume strategy. And there is a range that is supported by evidence-based medicine, and that is 4 to 8 mLs per kilo of ideal body weight. We're going to deconstruct that a little bit. We're always very cautious about the pressure that we allowed at the end of inspiration under static conditions, and that is the plateau pressure. We try to keep it below 30 centimeters of water. And recently, since 2015, if we can still call that recently, we're paying attention to drive-in pressure, which is basically the difference between your plateau and your PEEP in volume control ventilation. And evidence have shown that whenever that pressure is 15 and higher, the mortality increases in patients who are mechanically ventilated with ARDS. And the PEEP amount, with the closest evidence base have been able to achieve, is calling it enough PEEP. So there is a clinical trial for every method of PEEP titration, and all of them has been proven to be negative to improve outcomes. At the end of the day, personalization of PEEP strategy based on lung recruitability, oxygenation, and effort is what we need for lung protective mechanical ventilation strategy. Again, this is the evidence for airway pressure monitoring, and as you can see, sometimes it's too pretty to be true, and those that experience COVID and intubated and reintubated patients with COVID-19 will realize that sometimes it's just simply impossible to achieve that goal of a driving pressure less than 15. And we're going to discuss that shortly here. But it's the closest we have to personalization of mechanical ventilation based on the pulmonary mechanics of the patient. And we know it at the bedside as plateau minus PEEP, but really what is behind is a very significant amount of physiology. So the driving pressure is really integrating all the things that we pay attention to at the bedside. That includes tidal volume, respiratory system compliance, PEEP, and plateau. So the real equation of driving pressure is trying to normalize your tidal volume by your respiratory system compliance. However, if you remember those equations that we reviewed earlier, respiratory system compliance is tidal volume over plateau minus PEEP, right? So if we have a constant tidal volume, we end up with plateau minus PEEP. But that is only true if your tidal volume is constant. If your tidal volume is changing between breaths, your airway driving pressure might be different. It's also important to underscore here that this calculation should include any degree of auto-PEEP that we may see in patients who are mechanically ventilated. So doing an expiratory pause is actually needed to appropriately calculate airway driving pressure. And it's used commonly to titrate PEEP. It's a common indicator of mortality, as we discussed earlier. And it can give you an idea of either worsening of the condition that you are treating and that is leading to mechanical ventilation on your ICU patient, or it can give you an indication that things are getting better over time. Whether it is actually a cause of ventilator-induced lung injury or simply a representation of what is happening with the underlying disease is still not proven by evidence-based medicine. Also important to remember, the driving pressure can be actually higher, or your plateau pressure can be actually higher than your peak pressure, which is sometimes a misconception. Looking at your peak pressure, if it is 25, well, there's no way your plateau pressure is more than 30. Well, remember the equation of motion, right? The pressure that we might be seeing on the ventilator might be falsely reduced by the patient effort of the patient. So sometimes if we are able to inject an inspiratory pause in a spontaneous mode, you can actually see a much higher pressure under static conditions. And of course, that may affect your calculation of airway dry breath pressure in spontaneous modes. It's also important just to keep in mind a very algorithmic approach to how to identify, especially in these questions or at the bedside, whether a mechanical ventilation is actually lung protective or not. We can start with a tidal volume prescription, and we can ask whether this is safe or not. Again, we discussed that usually we think of lower tidal volume strategy, 6 to 8 mLs per kilo. The ultra-protective tidal volume strategy that is also supported by evidence base includes 4 to 6 ml per kilo of ideal body weight. This was initially conceived to be used using alternative modes of gas exchange, such as extracorporeal gas exchange methods. And it's important to keep in mind that if that calculation is getting closer to your anatomic dead space, then that may actually compromise your middle ventilation significantly. Then we perform an inspiratory analysis, asking us whether the plateau pressure is within safe range or less than 30 centimeters of water. Then we look at oxygenation, the triggering of the patient, the presence of auto PEEP, and also hemodynamic effects of your mechanical ventilation strategy to determine if your PEEP is adequate or not. And then we pay attention to your airway driving pressure, trying to keep it less than 15, and trying to determine if there is possibility to increase your PEEP if the lung is recruitable and you can actually open up more lung and reduce your plateau pressure, or if you're using inappropriately high levels of PEEP in patients that are very rigid and that will not respond to high PEEP levels. So keeping that algorithm in your mind will help you address some of these questions. Very briefly, I have put here for your awareness different methods of titrating PEEP that has really not been proven to favorably affect outcomes in patients with ARDS. We have those methods that basically look at pulmonary mechanics of the patient. We have methods that look at oxygenation-based methods, that is the LOF and the alveoli and the PEEP FiO2 tables that we commonly use in the ICU. And something that I would like to review with you here shortly is the esophageal pressure monitoring. They use the transpulmonary pressure that we discussed to titrate both PEEP and tidal volume. We use a esophageal balloon for this. Again, esophageal pressure is your surrogate for your pleural pressure. And what we do is basically trying to estimate your transpulmonary pressure. As we discussed earlier, your alveolar pressure at the end of inspiration, at the end of expiration is going to be your total PEEP, and then you will have a measurement of your esophageal pressure. And your plateau will represent that alveolar pressure at the end of inspiration. And what this technique of titrating PEEP and tidal volume does is basically using these calculations with the idea that a positive transpulmonary pressure means that your alveolus is inflated, and a negative transpulmonary pressure means that your alveolus is collapsing. So we want to avoid atelic trauma or opening and closure. So we want to use a positive transpulmonary pressure across the tidal cycle, right? We want to maintain a positive transpulmonary pressure at the end of expiration and a positive transpulmonary pressure at the end of inspiration. And there are certain parameters for doing that. So the goals are trying just to keep it above 0 for your transpulmonary pressure at the end of expiration, and not more than 20 at the end of inspiration. This is what was tested in the New England Journal of Medicine trial, EpiVen-1, showing that this method of using esophageal pressure may result in better oxygenation, but really wasn't strong enough to prove any kind of outcomes in terms of ventilator days or mortality in patients with ARDS. A follow-up trial in 2019, the EPIVEN2 trial, showed that using the esophageal balloon provides more or less the same PEEP values that you will encounter if you use the high PEEP FiO2 table of RNETs. So again, no benefit in mortality, but it's something that is important to recognize for boards. At the end of the day, the optimal PEEP is a constellation of factors, right? So we want to do with PEEP what we are initially intended to do, which is oxygenating your patient. So if we are able to achieve a PaO2 that is more than 55, in theory with an FiO2 that is not generating a lot of alveolar toxicity, hopefully less than 60%, then we're able to check that. If your plateau pressure and your driving pressure are within goal, is also a good PEEP. But nobody gets a golden star if your numbers and your oxygenation is good, but your patient end up in 3 pressors because of your PEEP value. So also it's important to know that the best PEEP is the PEEP that we apply to those patients that are going to respond to it, meaning to patients that are recruitable, right? So keeping lung recruitability in mind is very important. Finally, I'm going to discuss with you briefly over the next last 2 minutes, the circulatory impact of positive airway pressure. So intrathoracic pressure is going to reduce your venous return and therefore reduce your RB preload. However, as we're going to see here shortly, your right ventricular afterload is going to increase because of an increment in pulmonary vascular resistance. So that might end up in increased RB work and in a reduction in that RB stroke volume, right? So because of interventricular or ventricular interdependence, anything that happens on the right side is going to be translated to the left. So if you have a reduction in preload in the right ventricle, you will result eventually with a reduction in preload of the left ventricle. The beauty here is that because of the positive pressure, the transmural pressure of the left ventricle is going to reduce. And that will actually reduce the left ventricular afterload and make the pumping of that left ventricle more efficient. So we have an overall effect of reduction in cardiac output, but the efficiency of left ventricular contractility is going to be improved. And we see that benefit in patients with systolic heart failure and volume overload. So basically with the ventilator, you're doing everything you want to do for a patient with decompensated heart failure with an ejection fraction of 20%. We're diuresing the patient, we're reducing the RB preload. We are also creating a transpulmonary gradient towards ejection of blood towards the abdominal compartment. So the afterload reduction is going to help contractility and ejection of the left ventricle. So that 20% is going to be more efficient. So if we undo the effects of positive pressure ventilation without removing the excess amount of volume in a patient with systolic heart failure, that introduction of active ventilation or negative pressure ventilation is going to undo those positive effects and pull the patient again on respiratory failure if we don't fix that hypervolemia. Lastly, we have a brief commentary about the relationship between lung volumes and the pulmonary vascular resistance. So very briefly, we have a group of alveolus here that is at rest, and we have a group of alveolus here at the end of inspiration after inflation. So as you can see, the intraalveolar blood vessels are being compressed by the increase in intraalveolar pressure. So this pulmonary vascular resistance is going to increase. However, because of the extraalveolar interstitial traction, these extraalveolar blood vessels are going to be actually dilated at the end of inspiration. So those blood vessels, pulmonary vascular resistance is going to decrease. So when you put those two graphs together, you end up with the classic U-shaped form of pulmonary vascular resistance relationship with lung volumes. And the best relationship occurs in FRC. What that means is that if I am delivering a tidal volume of this size closer to FRC, I'm going to be generating this much change in pulmonary vascular resistance. But if I take this patient to a higher PEEP level and deliver the same tidal volume, the pulmonary vascular resistance is going to increase significantly and potentially cause right ventricular strain. So it's important to keep in mind concepts such as patient self-inflicted lung injury and other aspects of the effect of positive pressure ventilation on diaphragmatic muscle atrophy. So these are the concepts that we are going to leave for your review, are important, but for interest of time, we're going to move to the next talk. All right.